Everyone. Okay, you got your warning. We're recording this meeting. There was a big request from our last one where people wanted to be able to watch it later. So we did have that for the discussion, but we didn't have that for the whole program. So hi, welcome. So glad you are here. My name is Sarah Jones. I'm the CEO of PMD Alliance, and I am honored to be here today with all of you. And I'm honored to be here today with some incredible experts who are going to continue the conversation about Lewy body dementia, because we have about, 20 or 30 questions that, if you guys run out of questions, we have about 20 or 30 that were left over from last time that we couldn't get to. Before I jump in, I want to just kind of orient you. If you're new to this, I know most of you are not. But if you go to the right corner, in the top corner, there's a little button and you can click view and you can see the Brady Bunch view and everybody's faces, which I love because then I get to see all of your lovely faces. Or you can click and see the speaker view, and that's just going to be, right now my big face, but whoever's talking. In the bottom, there's the chat button, and you can press that button to pull up the chat and ask questions, make comments, whatever you want to do there. And I'm going to kick us off. So a couple things. One is I'm going to tell you about the two amazing experts that are with us today. And I thought maybe we would ask Ava Butler, who is going to be joining us in a few minutes. She's one of our board members, and her husband lived with Lewy body dementia. And she's really quite amazing. And so I thought maybe she could kick us off with just a few minutes of her story, and then we can dive right into questions. Does that sound like a good plan? Dr. Weintraub and Dr. Shprecher, does that sound like a good plan?
Yes.
Okay, cool. Well, I really want to tell you all about the amazing people you're going to have an opportunity to hear from today, because, it's really quite a treat to be not just to be able to hear from these doctors once, but now twice. So Dr. Shprecher serves as Movement Disorder Director at Banner Sun Health Research Institute in Sun City, Arizona, and is Clinical Associate Professor with the University of Arizona, Phoenix. Prior to joining Banner in 2015, he started the Movement Disorder Clinical Trials, Tourette Association of America Center of Excellence, and Huntington's Disease Society of America Center of Excellence programs at the University of Utah in Salt Lake City. He's inspired by his personal experience as an individual with Tourette syndrome and has dedicated his career as a movement disorder neurologist to improving treatment options and quality of life for movement disorder patients. In addition to a long history of site investigator activities in movement disorder clinical trials, his observational research with Banner's brain and body donation program and the North America prodromal, okay, help me. I can't even, I'm going to butcher it.
Synucleinopathy.
Synucleinopathy. See, it just rolls off if I don't have to read it. Synucleinopathy consortium is aimed at improving early diagnosis of and biomarkers for REM sleep disorder. And as many of you know, that is a really significant issue for people and is a risk factor for Parkinson's disease and Lewy body dementia. So the ultimate goals of his work is to guide the design of trials aimed at delaying or preventing these illnesses entirely. And so welcome, Dr. Shprecher. We always love having you on. Thank you for being with us and taking time to share with us. Daniel Weintraub is the Assistant Professor of Psychiatry at the University of Pennsylvania and Fellow at the University of Pennsylvania Institute of Aging. He completed his medical psychiatry residency and geriatric fellowship training at the University of Maryland. His areas of research include psychiatric and cognitive complications of Parkinson's disease. He's a current recipient of a 5-year Career Development Award from the National Institute of Mental Health, titled Depression Diagnosis and Treatment in Parkinson's Disease. So important, something we don't talk about enough. That's my 2 cents. In addition, he's currently coordinating investigator for multiple site international industry-sponsored study of the frequency and correlates of impulse control disorders in Parkinson's. He also served on 3 Movement Disorder Society task force to revise and make recommendations for the assessment of non-motor symptoms in Parkinson's disease, and is a member of the Scientific Review Committee of the Parkinson's study group. So you can tell that you are with some pretty amazing experts who are sharing their time with us today. So thank you for that. Really, really grateful. Ava, I wonder if you might just share just a couple minutes of your experience. I think one of the things that helps ground us as we have these conversations, and one of the richness that we get to have in these conversations, is getting to a real discussion as opposed to in the real life experience. And I happen to know from the privilege of talking with Dr. Weintraub and Dr. Shprecher, they're really great at engaging at that level. So would you maybe just share just a few words about what it was like to love somebody who was dealing with this?
How can you say, what was it like to love somebody who's got Parkinson's and Lewy body dementia? I would say rich. I would, as just one word. And rich in many ways, and full of joy and happiness and sorrow and tears and frustration and all those emotions. But looking back, because my husband has passed away in March of 2017. So looking back, it's really just richness and joy and love, I would say. So I was just looking on my calendar. It was March 27th, sorry, no, March 26th. So in 2010, so 10 years ago, 11 years ago, that my husband, Richard, was diagnosed with Parkinson's disease. And at that time, I just thought, well, so what? His hands are going to shake a little bit and, not a big deal. So I did not understand the journey we were about to go on. And in fact, in hindsight, I really think, and there's no clinical diagnosis, so this is just my view. He might have had Lewy body dementia, and I forget the exact words, but if it is dementia with Lewy bodies, or exactly what that. But looking back, he had symptoms around paranoia, depression, some of the Lewy body more cognitive issues, even before some of the physical issues started coming up. But we didn't understand that. He first thought he had anxiety disorder because he was getting so anxious, such as being afraid to fly in planes. Now, I fly a lot for my business. I'm an organizational development consultant. And so I have lots of air miles. We were flying first class to Europe using my miles. And he was so afraid of flying, even though we've done this for decades, that he literally looked at his watch every 3 minutes for a 10-hour flight. Like, wow, how something's not right here. But we didn't know what it was. He later started having hallucinations, and not the nice 1960s kind, like some of us might remember, but just really fear-based. There are bad guys in the house and guys with tattoos on their teeth and running after us, and all kinds of issues of really scary paranoia and hallucinations that we didn't understand. And just a little bit like Robin Williams' case. Now, Robin and his wife unfortunately never knew about Lewy body dementia. After a few years, we kind of figured it out. But we didn't have a neurologist that told us. We just kind of were reading and learning and figuring it out. Our neurologist even said, no, hallucinations aren't part of Parkinson's. A lot has happened in those 11 years, and I would pray there's not a lot of neurologists that would say that anymore. But it was a journey that was full of lots of surprises. I'm so grateful for groups like this, because I did not know. I learned through my own learning without a lot of coaching or mentors or support around Lewy body dementia. So I'm really happy to be here. I had written a memoir on my experiences called Parkinson's, a Love Story with Dementia for Dessert. And I think because of writing that, that's how I got to connect with you, Sarah, through mutual friends here in Tucson. And I had the pleasure of speaking at when we were in person in Tucson, and we're hopeful that we'll be in person again soon, starting. And I think I spoke with you in with your group in 2018, 19, maybe, Sarah?
I think that's right. I think it was 2019.
Yes, in a delightful, carefree time.
Yes.
And then I had the privilege and honor to join the board and have been a board member for, I think, 6 months, Sarah?
Sounds about right. Yeah.
So I'm really excited. I'm so excited about the work, about this organization, about these webinars, the fact that COVID had a few good things, which means that we're all together from so many countries and places. So I'm really thankful and happy to participate.
Oh, thank you so much, Ava. Thank you too for sharing your personal experience. I just think it helps to ground us in the reality. And I'm certain that what you shared, there are people who are listening who say, oh, yes, I feel that. And I think anytime we can help each other feel less alone in these confusing and overwhelming issues that this disease can present and these diseases can present. So thank you very much, Ava, for sharing.
My honor.
And I wonder, before we dive into questions, Dr. Weintraub, Dr. Shprecher, is there anything you'd like to share, either as you've reflected on our last conversation or, kind of kicking off today?
Well, you go first, Dave.
I think one important question, people posed to us when we gave a panel talk about the SPARK movie and Robin Williams' story, people said, well, would you guys have figured it out? And, his doctors really didn't have a lot of time to work with him. And I think we often have, Dr. Weintraub and I often have this luxury of the passage of time. By the time somebody gets to us as the specialist, there's been a lot of time for symptoms to evolve, and the diagnosis may be more straightforward to us. But this is really important that during these panel talks, you kind of get to hear what symptoms you should be looking for so you can bring those to the attention of your treating clinicians.
And I think I just want to say I'm ready to handle questions, comments, and so I'm ready to move ahead.
Fantastic. Well, I'm going to just jump into some that we weren't able to get to last time. And then also people are welcome to put conversations in, and ask some questions as you have it. So one of the questions is, can PTSD mask a diagnosis of Parkinson's disease dementia or Parkinson's disease psychosis, Lewy bodies, any of that?
I work in the VA system, so I'll start with that. I don't think so commonly. I'd say that the overlap in a specific symptom would be dreams that or nightmares that people with PTSD commonly report, and that would be true in the veteran population as well. And the vivid dreaming behavior, or RBD, idiopathic rapid eye movement sleep behavior disorder, also known as RBD, where patients often with Lewy body dementia have that and are verbally and physically acting out their dreams. Sometimes there can be difficulty telling those two apart, the vivid dreams of PTSD and the dream enactment behaviors of Lewy body dementia. I'd say other than that, PTSD is associated with many psychiatric complications, but it isn't really associated. It may be a risk factor in some epidemiological studies for the development of Parkinson's disease down the road. That and both traumatic brain injury or closed head injury may be, but I wouldn't say that they're really commonly confused or difficulty telling them apart as diagnoses.
Yeah, I think sometimes some doctors get confused about whether someone who has PTSD also has REM sleep behavior disorder. They certainly can have both. And we've been working with colleagues in the VA system in Portland, and they study this a lot. There does seem to be a higher rate of REM sleep behavior disorder in their veterans with PTSD. We don't know if that's somehow an actual trigger for this illness years down the road of Lewy body dementia or Parkinson's. That's subject of ongoing research.
Great, thank you so much. By the way, I'm reading the questions from the last one that we didn't get to. So, and again, feel free to add questions into the chat here. So this one was, so I understand that there's no cure. If it's diagnosed early and there is treatment, first of all, is there treatment? And if there is treatment, does that help to slow it down?
We can alternate unless there's a clear question directed
Sure.
to me or David. Do you want to go first, David? And I'll follow up if needed.
So it's not clear that any particular treatment actually slows the progression of Parkinson's or Lewy body dementia. However, if we're giving a treatment that's a memory enhancer, this may also improve hallucinations or acting out of the dreams. Then that may appear to slow the progression of the memory loss in that regard, because people get back somewhat to a higher level of function. But there's no evidence that any of these treatments actually slow or hasten progression of the illness.
And all I was going to add was, in addition to agreeing, was that I think it's an area of very active research. And that's true not just for Lewy body dementia, so Parkinson's disease dementia with Lewy bodies, Alzheimer's disease as well. And I'd say more and more they're testing therapies that are hopefully not just symptomatic therapies like we have now, but potentially disease modifying therapies by attacking the disease pathology process directly. And that's one in a very active area of research. And also they're trying to move the studies earlier and earlier. So not waiting for people to be so advanced in terms of their symptoms, but as early in the process as possible, so that if these therapies work, that they'll have the greatest benefit to patients and their loved ones.
Great. This made me think about what kind of therapies are there? Are there therapies, medications, treatments that can be added for Lewy body dementia? Speaking specifically for Lewy body dementia.
Well, starting with Parkinson's disease dementia, we have the core symptomatic therapies to manage the motor symptoms of Parkinson's disease that are used most commonly in Parkinson's patients and Parkinson's dementia patients as well. There are cognitive enhancing medications that can be used for the cognitive symptoms. Those are actually medications that were first developed and approved for Alzheimer's disease, but have been extended to use in Parkinson's disease dementia. There are treatments for some of the symptoms that commonly occur with patients with Lewy body dementia. So you heard from Ava before about anxiety symptoms, psychosis, things such as hallucinations. So we have psychiatric medications that can be used to help manage those symptoms. And I'd say it's pretty much the same for dementia with Lewy bodies. We have the cognitive enhancing medications for the dementia. We have the Parkinson's type medications for the Parkinson's symptoms, and we have the psychiatric medications for the psychiatric symptoms, all symptomatic therapies at this point.
Can I add one point?
Mm-hmm.
And this is not about, pharma drugs, but I think it's important for people to know that there are things that are in your control, like what you eat. For example, my dear husband was a sugarholic. I mean, he would eat anything sugar all day long if he could. And we worked very hard once he was diagnosed to get away from carbohydrates, sugars, processed foods, etc. And I could tell a big difference in his cognition. If he had a gigantic bowl of his favorite ice cream, within 2 hours, his cognition would go down. So that's just a personal example. So managing what you eat and how you have, and then of course, exercise is such a big deal. I mean, it really does help. It's not a cure, but it helps. All the kinds of things that you can do, the different therapies, etc. Am I allowed to talk about a pharma drug that did help him or no?
Yeah, you can do that, sure.
I know it does not help for everybody. So do not, everybody on this call, do not think this is the magic pill for you. But for my husband, Nuplacid helped tremendously with his fear around his hallucinations. He was much less, he still saw things, and he'd be looking over your shoulder and, you know, seeing things, but for him, it really helped with the fear. So that was helpful to us. As I said, it's not necessarily helpful to everybody.
Thanks, Ava. And I noticed Dr. Shprecher, you nodding, I think around maybe the nutrition and also the exercise piece. I think I saw you nodding. Did you have thoughts about that?
Yeah, I agree. It's important that, moderation is key with all of these things, both with the carbohydrates, but also even with exercise. So, moderation. But to your point, when people overdo the carbohydrates, some people find, not just because it affects their other health conditions, but it also can worsen confusion because it may dilate blood vessels and cause problems with fluctuations in the blood pressure. So when we're thinking about treatment of symptoms, another one that often gets overlooked is a problem with orthostatic hypotension, where people have a low blood pressure when they're standing up. And that's a condition where sometimes just identifying triggers like too much blood pressure medicine when it's no longer needed, or too large a serving of carbohydrates at a time can be an initial approach. We don't necessarily need medication for every symptom. There are lifestyle changes that can be helpful.
And I was going to just add from Ava and David's comments, as physicians, we're often asked to focus on pharmacologic approaches or medication approaches. And but I did want to emphasize that there is a whole other aspect to managing and trying to prevent further changes that are non-pharmacologic. You've already heard some of them: physical exercise, cognitive exercise, diet, managing problems such as orthostatic hypotension, avoiding medications that may be harmful in terms of cognition, managing other medical conditions that can affect memory, cognitive abilities, such as diabetes, high blood pressure, high cholesterol. So these are all things that don't involve taking additional medications. There's also very skilled psychotherapists and counselors that are can be very helpful in working with people, patients, family members around management of behavioral issues or specific psychiatric symptoms that, again, don't involve taking additional medication.
Thank you. And you know what's striking me as you're talking about all of this, because I know we have couples on here. I know we have care partners, maybe without their loved one on here. And I think all of this can be sort of applied to care partners as well as the person with the disease. So whether we're talking about anxiety or depression or, all of that, I think it's really making sure that, the whole system is being attended to. I'm sure that you guys see that in your practice, Dr. Weintraub and Dr. Shprecher, the strain on care partners.
Yes, without a doubt, it's huge. Particularly when there's behavioral issues involved, I'd say.
Right.
And I think that's why Lewy body dementia, Parkinson's dementia, dementia with Lewy bodies is often a much more difficult illness, even than something like Alzheimer's disease, as difficult as that is, because that tends to involve primarily cognitive problems, maybe less so behavioral problems, and certainly less so the neurological complications, the Parkinson symptoms. With Lewy body dementia, you really hit on multiple fronts in terms of making things very difficult to manage.
I'm curious if you have some ideas for care partners, for loved ones, for spouses, for adult children. When somebody's dealing with these kind of things, a hallucination or a delusion, or maybe not the behavior pieces, but some of those pieces, how do you recommend, Dr. Shprecher, as you're talking with a patient and a family, how do you recommend that they interact with that? I think sometimes people get into arguing about what's real and that's not always the most effective.
Yeah, that's an important problem, is that each individual situation we have to kind of gauge how do we avoid escalating, because if we kind of argue about the hallucinations, it can cause a person to get upset and agitated. and some people respond well to being reminded, what's a hallucination or not. So this is where we have to kind of help the families decide case by case. An important part of the team in most memory movement disorder clinics is a social worker. A social worker doesn't just help people apply for disability and make sure they have their affairs in order down the road, but they really serve as a counselor, not just for the patient, but for the caregivers and the family. And I think people sometimes put that off a little bit too long, don't see the value of involving the social worker early on to give advice for situations like this. I can help decide, which medications we can adjust that might be bringing out the hallucinations more, or which treatments may be safest to treat the hallucinations. But we often need this advice about how do we manage day to day, with a non-medication approach.
Right, absolutely. So somebody's wondering, is all dementia in Parkinson's related to Lewy bodies, or are there other causes? Dr. Weintraub, do you want to take that one?
Maybe you could say the question once more, just so I can make sure I understood
You bet.
it.
Sure. Is all dementia in Parkinson's related to Lewy bodies, or are there other causes for dementia?
So in terms of the underlying disease pathology, to call it that contributes to dementia in Parkinson's disease, there's maybe three components. One is the underlying Parkinson's disease pathology, and what's different maybe in somebody who has dementia versus somebody who doesn't have dementia, but both people having Parkinson's disease, is that Lewy body pathology spreads more widely throughout the brain, beyond the areas of the brain that are responsible maybe just for the motor symptoms. And it affects areas of the brain that are more responsible for thinking and reasoning abilities, and maybe visual abilities that may contribute to hallucinations, for instance. So it's the widespread nature of the disease pathology. There is a percentage of patients with Parkinson's disease dementia who also have Alzheimer's disease pathology to some extent. So having Parkinson's disease doesn't make you immune from having some Alzheimer's disease pathology as well. And the older somebody lives, the more likely they are to have that what we call comorbid Alzheimer's disease pathology. And then finally, having Parkinson's disease doesn't make you immune from those other problems I told you about: high blood pressure, high cholesterol levels, diabetes, obesity. So those are also problems, conditions that are associated with cognitive changes as well. So if a Parkinson's patient has those problems, they may have cognitive changes related to that. So those are probably the three main factors at this point as we understand them. There are other factors as well, but that probably explains a lot of it.
Excellent. Okay. So I saw a few questions about DAT scan, and there wasn't this specific question, but I just wonder, maybe Dr. Shprecher, kind of clarifying the purpose of a DAT scan, because just so people know, if there's some thought that maybe a DAT scan is going to show Lewy body dementia, maybe to clarify what a DAT scan actually does and does not do.
Yeah, and there are some neurologists who just are not comfortable with how to examine a patient and determine if they have Parkinsonian symptoms or not. And I don't personally believe that's a good reason to order a DAT scan, but it seems to be the most common reason that patients coming to my clinic for a second opinion have had the test. And it's an expensive test that is covered by Medicare, but the copay can be, upwards of $1,000 for some people, depending on what type of Medicare they have. So the value of the DAT scan is when things aren't quite adding up and we're trying to decide whether the symptoms actually fit with degeneration in the brain as a cause. For example, if someone mainly has tremors, we're trying to decide between essential tremor or degeneration in the brain as a cause. Or if they're taking a medication that's in the antipsychotic family, then we're trying to decide if those symptoms are actually a side effect or it's really unmasking degeneration in the brain. So those are the good reasons to order the test. A third scenario where I use the test, and many of my colleagues do, is when the slowness is kind of subtle, and the tremor is very mild. And it's hard to say that this is, necessarily due to degeneration in the brain. Then that test, the DAT scan, actually constitutes an important piece of information. If it shows degeneration in the brain, that counts towards the diagnosis of dementia with Lewy bodies. So in cases where we're unclear whether someone has clear-cut Parkinsonism, that's a clear sign of degeneration in the brain, the scan can be very useful. Unfortunately, the majority of the time when it's ordered outside of a specialty clinic, it's really being used because people just aren't comfortable with the exam, in my opinion.
Great. Okay. Really good to clarify, to know what to expect, right? Because I think you've shared with us and you shared last time, really the diagnosis comes in an autopsy. Is that correct?
Well, certainly the only way to make a definite diagnosis is based on an autopsy. However, when people fit all the criteria we use to make a diagnosis and they continue to over a few years of follow-up, our confidence in the diagnosis can be quite high, but it should not be 100%. And I had a direct message from one of the participants asking, in follow-up to what we just discussed, what can we tell them about prognosis? And unfortunately, we don't have a good algorithm yet to tell people exactly what time course to expect. However, I think we both agree, Dr. Weintraub and I, that when somebody has pronounced memory and thinking problems early on in their course, whether it's in the first year or the second or third year, they tend to progress more quickly with the condition than when it's mild from the beginning and remains mild for many years. I don't know if you have any to add about prognosis, Dr. Weintraub.
No, I agree with you. I think that's why dementia with Lewy bodies, I think you mentioned this last call, Dave, tends to have a more rapidly progressive course than just Parkinson's disease in general, because many patients with Parkinson's disease don't develop significant cognitive impairment until later in the course of the illness.
And along that lines, talking about timeline, somebody asked last time, how early in life can Lewy bodies be found? Is there an age that is typical for diagnosis? Is there an age that, boy, you're not going to get this diagnosis any earlier than such and such is there any age parameter?
Well, in people who don't have any other genetic conditions that are associated with Lewy bodies, it's extremely rare to see this, or to see Parkinson's in general before the age of 40. So that's why we call it very early onset Parkinson's, when people develop Parkinson's disease before the age of 40. So there are genetic conditions, including mutations in the gene that is associated with the protein that's in the Lewy bodies, alpha-synuclein, that can show early Lewy bodies. But for the most part, this is something that we see more often in people who pass away, that are 50 and over.
Okay, good to know. Another person wondered last time, is the person with Lewy body dementia fully cognizant of the disease course? Do they have awareness that this is happening and progressing?
I would say early on, this is kind of a general rule of thumb, not specific maybe to dementia with Lewy bodies or Parkinson's disease, but I think the more cognitively intact the person is, then the more likely they are to have insight or awareness into their symptoms. And so people with normal cognition or mild cognitive impairment or even mild dementia may have some pretty good awareness, even mild dementia. Once you get more to the moderate and then later stages of dementia, I think the awareness becomes much more impaired. People's memories are failing them at that point. Their ability to reason is not the same. Their ability just to communicate, their language abilities are declined, their ability to pay attention. So for all of those reasons, I think awareness and insight, people can become more amotivated or apathetic, as we call it, as that cognitive impairment progresses. That also makes them less probably aware of their deficits. So we've become kind of, as clinicians, increasingly reliant on family members, care partners to provide us key information moving forward.
Can I add to that a little bit? For Richard, he knew something was wrong, very wrong, but he didn't know what it was. And of course, I didn't either. And was a very intelligent man, and he tried to figure it out, like, what's going on with me? Like, he knew that he's having trouble with the banking. He knew he was seeing things that, and his hallucinations felt pretty real to him. I mean, it was like they were regular people, but he knew he was very conscious that something was very wrong. And he never fought with me about having to deal with issues proactively. And I think that's different. Like right now, my mother has Alzheimer's and she's fighting us. I mean, it's completely different. My personal experience with Lewy body dementia and my husband versus, other kinds of dementia.
Yeah, thank you very much for sharing that, Ava. It's tricky, and there's actually a few questions specifically around care partners, and I'm going to ask for your thoughts on this. I think your thoughts on this as physicians and also kind of experiencing and seeing what has happened over the years with the family system. And also I think Ava, your insight is also helpful with this. There's quite a few questions about care partners and caregivers. And when we use care partners, we're often thinking about spouses. We're usually talking about familial carers, not paid caregivers per se, when we're talking about this. So one of the questions last time was, do care partners get sympathy symptoms? And if so, what are most common? And I'm curious if you can talk about that sort of experience, either or both of you. Dr. Weintraub, do you want to start?
What is a sympathy symptom? I'm not sure what it is.
I don't know, because let's see if that person is on. I don't know who asked that. I'm going to guess that sympathy symptom, I mean, I doubt that it's the hallucinations. I'm going to guess that it has to do with kind of that anxiety, but I could be wrong. And if there's anybody that, that asked that question and wants to share, would love to hear a little bit more.
So is the question whether the care partners experience psychiatric type symptoms?
Mm-hmm.
I mean, I think if I understand the question correctly, and again, like you said, the person can clarify what they mean if we're wrong. I think caregiver burden is very real, and that often manifests itself as, it can manifest itself as anxiety symptoms, as depression, decreased quality of life. And it's just, I think, an overwhelming responsibility, not, of course, for the patient, it's the biggest problem, but it's an overwhelming problem and responsibility for many care partners as well, particularly those that are, trying to have the patient stay at home for as long as possible and maybe with limited resources. And it's often the behavioral symptoms that end up making the final straw that breaks the camel's back, so to speak, in terms of a care partner not being able to make it at home anymore with the patient. If a patient stops sleeping, so the care partner's up all night or a good part of the night too. If the patient becomes agitated or acts out on hallucinations or delusions in a way that becomes very problematic for the family, for the care partners, that can often be the final straw. Yeah, but again, I don't know if I understood the question exactly.
Yeah, I wish I could tell you directly, but it was just one that was written last time. So I thought it was,
okay.
And so a couple people did say maybe it's like when men feel pregnant when their wife is pregnant, or transference. So I think to me, what I think of my my father-in-law, who he was never diagnosed, and I think that was probably just because it was too new and in terms of people's recollection and recognition, but he clearly had these symptoms. But I know I always told my mother-in-law that she had Parkinson's too, and I think that shared long-term disease is a very real thing, that can become one big ball of where does the disease stop and start, since everybody's navigating it. Yeah. And Kelly put in the chat, just so you know, there's some, resources. There's been some great conversations in the chat about different books that are helpful. So, we can always pull those too and send those to you and let you know what those are. We'd be happy to do that. We'll make sure they're on our site too. But we also have a program called Getting Real Online. And that's a really great program that really has in-depth conversation, videos to watch. So you can watch them at any time, day or night, because we know care partners and caregivers are very busy and it's hard to carve out time sometimes to watch something. But there are videos and resources for all different kinds of challenging issues that people face as the disease progresses. So you can join that as well. Does carbidopa, levodopa have a relationship to blood pressure and orthostatic hypotension? And, I'm thinking, Dr. Shprecher, you referenced this earlier, but I would even take this to not just carbidopa, levodopa, blood pressure, orthostatic hypotension, but also orthostatic hypotension with Lewy body dementia and dementias.
Yeah, I think it's an important question whether any of the Parkinson's medications can increase this or bring out this problem with the low blood pressure standing up. And the answer is they can, and we want to monitor carefully for that problem as we add or increase the dose of any of the Parkinson's medication, even levodopa. And so there are, individuals who are taking carbidopa, levodopa that have problems with nausea as well as with dizziness, and it has to do with the activity of dopamine that's being created from that levodopa before it gets to the brain where it's needed. And so that's where you need to talk to your treating clinician about measures to take if you're seeing problems with increased dizziness after adding or increasing the dose of carbidopa, levodopa.
Sorry, I muted. I almost had you have to say for the first time today, somebody would have had to tell me I was muted. Okay, so let's see. Let me grab another question. Was there something you were going to say, Dr. Weintraub, related to that? Okay.
No.
Let's see. So my next question that I have here is, if you have REM sleep disorder, will you always end up with Lewy body dementia?
I can start with that, and I know Dave's involved in this area too, but I think the increasing evidence is that if you have what we call idiopathic RBD, which means you don't have a diagnosed Lewy body disorder already, so just you have RBD in midlife, the likelihood that eventually you'll develop a Lewy body disorder is very high if you follow people long enough. And the two most common diagnoses would be either Parkinson's disease or dementia with Lewy bodies. It can go to either direction, although they're both considered Lewy body disorders. So it does seem to be a pretty strong marker for something that's going to happen at some point.
Yeah, I agree exactly. And unfortunately, it also can be a risk factor for earlier problems with dementia in people who just have Parkinson's in the beginning, if they had already had REM sleep behavior disorder beforehand. But that's why we're doing all this research to better understand that and try to do something about it.
Great. And maybe you could quickly just explain for people who don't know what REM sleep disorder really is. Just a quick overview for that. I think people don't always know about that, and it can be difficult to talk about and difficult to actually plan safety for that.
You go ahead, Dave.
Yeah, normally during the more active stages of dreaming, when our eyes should be the only thing that's moving, that's why we call it rapid eye movement stage of sleep. Some people, their other muscles may still be active, and that's not normal. So when you see a dream sequence on a TV show and somebody kind of jumps out of their bed and yells out loud after having a nightmare, that's actually not a normal thing. And if it happens on a recurrent basis, more than once, then it raises concern someone could have REM sleep behavior disorder, particularly if they wake up and are asked what they were dreaming about, and the movements that they have, like throwing a punch, actually fits what they're dreaming about, that they were protecting their loved one from an intruder. And so it can be dangerous. And when somebody develops this during the course of Parkinson's or Lewy body dementia, we need to take measures to make the sleep environment safer. So, have a bigger bed, move furniture away that they could be injured from. Some people will even lower the bed or put a mattress next to the bed or use bed rails, depending on what's appropriate for the individual situation. There are treatments that your treating healthcare provider may recommend, but it's important to talk to them about it first before trying anything. We sometimes will recommend melatonin, or we may prescribe clonazepam, but not something that you want to just go out and do on your own. You want to get guidance and decide what you really have and talk it over with your healthcare provider.
Can I just add that, sleeping next to a person with this REM disorder is a bit perilous. I mean, and I'm a very heavy sleeper, but I learned that once Richard would start to move, kind of wrestle around, wake up. There's more than one time, because they punch and kick. And more than one time I caught his arm before it smashed me in the face. Not because he's trying to hit me, but just because they're in that way. So if you're the care partner, just know, and you mentioned it, doctor, that plan ahead and know that that's something that is an issue.
Thanks for sharing that. I really think it's one of those conversations that doesn't happen probably often enough. It's a hard conversation. I mean, who wants to have these conversations? It's difficult. And so, but avoiding it has some real potential safety issues. This makes me think about, these difficult conversations make me think about something that I feel like we've been seeing. And I think it's a byproduct of COVID, and maybe people doing telemedicine, maybe people sort of like hunkering down and closing in, but I feel like there's a little bit less discussion. We did a survey of the impact of loneliness and isolation during COVID. And we had, 400, 500 people respond, care partners and people with Parkinson's. And we asked what symptoms were new and or significantly worsened during this time period compared to before COVID. And hallucinations and delusions was one of them. And I know from, you two, this is your specialty. You ask about this, right? I know you ask about this with your patients. I also know there's a lot of doctors who don't. So not in a critical way about other doctors, but I'm wondering if you have some recommendations, as people are listening and they're thinking, I don't know that my doctor's ever brought this up. Or, that kind of a thing. I think we've got to start surfacing it because the prevalence is pretty high. To not actually surface it. And I'd be curious if you each had some recommendations as people are listening, thinking, how am I going to bring this up with my doctor? Who's never brought it up with me. And
one important problem is that, in the real world, not every doctor has, 40 minutes with every return visit. I know in a lot of the memory clinics they do, and in our clinic, it's more like 30 minutes. But if you're going to a busy practice, or just that there are important things to bring up, have a list of priorities, but don't necessarily come with a list of 15 questions and expect that your doctor is going to have time to cover every single one thoroughly. But really have a list of what are the priorities you have going in. And if these kind of problems like the dizziness, standing up, or acting out dreams or hallucinations have been an issue, make sure you can at least get 60 seconds in edgewise to explain what you're really seeing. Because we had an important question just came through: is lower leg twitching or leg cramps part of REM sleep disorder? And guess what? If you just tell your doctor, oh, he's moving his legs, I think it's RBD, you might walk away with a prescription for the wrong condition if they don't actually stop and get the whole story. Because leg twitching can be a lot of other things. Muscle cramping can be a lot of things too. And that's where I don't want to go through the whole list of what it could be, but it's important that your clinician gets the story of what you're observing, so they can actually decide what it could be, and then kind of test their theory about what it is or what it isn't. Because it's a more complicated question than just yes or no.
I was just going to add that I think the scenario you described, Sarah, in my experience, which is biased dealing with Parkinson's disease, is probably more common with Parkinson's disease, just because there's so many different symptoms that can occur, and the neurologists that are treating it are often out of necessity and time, as David said, focusing on the motor symptoms and the complex medication or treatment regimen they're often on. And so other things fall by, not understandably so, fall by the wayside. So it is, I think, incumbent on the patient and the care partners to prioritize and bring up those symptoms if they're significant. I think when people are seen in memory centers or by psychiatrists, it's more likely that those symptoms are going to be covered anyway. Maybe other things get neglected, perhaps, but not the things you're describing.
That's great insight. Thank you. And I think this is one of those times where, you know, if your doctor has a portal, utilizing the portal to share the information, and also remembering, if, you know, I know we always have adult children who are listening. You can always send notes to the doctor. They may or may not be able to reply to you depending on what the confidentiality and what the agreements are, but they can always read notes from you. And that helps their understanding as well. So, you know, feel free to use your voice and do use your voice, because it is your life, and whatever is the most troubling for you is what you want to make sure you get prioritized in your appointments. Okay, so here's a question. My husband started acting out his dreams has acted out his dreams for several years. He started on carbidopa, levodopa, and they stopped, and now they're starting again. Is that a sign of Lewy bodies forming? I'm not sure who would want to answer that one.
It's a good one for Dave to start with, I think.
Okay.
Yeah, people can really fluctuate with this particular symptom. And occasionally we'll see the symptoms increase or decrease as the medications are changed. It's not always clear why. Certainly antidepressants can bring out REM sleep behavior disorder symptoms for some patients. But in some cases, those antidepressants are so helpful, particularly if they're also helping the person fall and stay asleep, and then therefore the caregiver can sleep, that we may actually use a treatment to help calm the acting out of dreams rather than change the other medicines around. But it isn't necessarily a sign of progression when that symptom fluctuates. So we want to think more broadly than that.
Great. Okay, perfect. So another question was, my husband does not have hallucinations and is much better than a year ago, and much less acting out and hitting me during dreams, I'm assuming, or during sleep, yes. So is it possible he is getting better? The diagnosis is Lewy body dementia. So do people just start to get better from that?
I think there's a couple of ways to answer the question. I think in terms of the underlying disease process, we're not really aware that things improve. I think in general, they may progress variably. So some people progress quickly, some people progress slowly. I don't think we really are aware of that disease process reversing itself in any way. That being said, the symptom profile can change over time, or does often change. And we might think that symptoms always just get worse over time, but that's not necessarily so. They can be variable. They're variable between patients or different between patients, but they're variable or different within patients over time. Sometimes patients change within a given day. They can change within a week or a month or over longer periods of time. And it's not always just worsening of a given symptom. There can be resolution of symptoms as well over time. It's hard to speak to a specific person and their specific symptoms. Sometimes there may be not only the disease process to consider, but other things going on, medications that have been started or stopped that may play a role. There can be multiple factors, and sometimes we just don't understand why these things happen anyway.
Okay, and Dr. Weintraub, I think this might be a question for you. Can you talk a little about the role of psychiatry in addressing and dealing with and serving people with dementia? Is it helpful?
Well, I think so, depending on the dementia, but maybe not so much. My experience has been in Parkinson's disease, so it's very colored by that, but I think it applies to dementia with Lewy bodies and Alzheimer's disease as well. I think working alongside other professionals that have a piece in managing a disorder is the best way to go. So I don't manage from a neurological perspective, so the management of the motor symptoms of Parkinson's disease, I leave that up to the neurologist. but I feel like I have a role to play in managing the psychiatric and even the cognitive symptoms. And I think there's other professionals, occupational therapists, physical therapists, neuropsychologists, social workers, psychologists, that all can have a piece in for different people and at different times and in different ways. So yes, but the bottom line is I think a psychiatrist should be a key member of a team if you have a dementia clinic or a Parkinson center or a dementia with Lewy bodies center. I do think that's important.
So making sure that's one of the people on your care team. You know, it can get overwhelming to have a big care team, but it's also really helpful because everybody has just a little bit of additional information that I think is really helpful. You know, and Dr. Shprecher, somebody asked about movement disorder specialists. Okay, so the question is the relatively low number of movement disorder specialists in practice an issue with diagnosis of Lewy bodies? Would you expect would you expect a movement disorder specialist to be able to understand and address issues and diagnose Lewy bodies?
Yeah, I mean, certainly we've come a long way. I have to kind of give my colleagues credit. In the last 10 years, we have come a long way, and I've been impressed that general neurologists do seem to do a better job of making the initial diagnosis in cases that are very straightforward. And it used to be even the straightforward cases were getting missed, you know, 10 or 12 years ago when I was initially starting out in practice. But there are some cases there where early on, the symptoms are rather subtle. And that's where the availability of that scan, people are asking the full name, dopamine transporter SPECT, that DAT scan has been helpful. So that is another tool that is available to our neurology community that aids in the diagnosis. When things aren't adding up, I like to say a good neurologist knows when to refer. So when things really aren't adding up, not just saying, well, it's dementia and the cause doesn't matter, but rather trying to get them to either a behavioral neurologist, geriatric psychiatrist, or movement disorder specialist is worthwhile. And I think in Arizona, that's not true. There are over 20 movement disorder specialists in the Phoenix Valley. There are 4 or 5 specialty centers for dementia. So it may be that people just aren't aware of the availability of the specialist, and they often get sent by the doctor their primary care doctor knows. It may be a general neurologist first. But in Arizona, availability of the subspecialist is not the rate limiting step.
And I think, you know, in this day and age with telemedicine, you know, I think the thing for all of you to know is, as you're out there, because I know we're just about out of time here, the thing to know is that, you know, we will always help you try to find somebody in your area. If there's not somebody in your area, maybe we can help link you up with somebody who can utilize telemedicine. But I think the most important thing is to get the specialist and get the care that you deserve. And I'm going to repeat my mantra of, if you had a specific kind of cancer, you would search out the doctor who was the oncologist who knew how to treat your kind of cancer. You know, I don't know a single person who's like, yeah, I don't care if that doctor knows about my cancer. Nope. You search that out always, and you deserve the exact same thing for movement disorders, for Lewy body dementia, and so does the care partner and the rest of the family. So, and there are wonderful, wonderful specialists out there like Dr. Weintraub and Dr. Shprecher, who again have given us an hour of their time, their precious, precious time, to answer these questions for us. We will make sure that you get all of this information that went into the chat, because there was a lot of really great solutions and ideas that went in there. There were a couple questions, one related to new medication, nilotinib. And so studies as it relates to proteins. So we will see about getting some presentations on that for you. We just want to thank Dr. Shprecher and Dr. Weintraub for taking your precious time again with us, and for sharing your expertise. We can't tell you how much we appreciate you. And thank you. And let's do our thanks by waving at them and giving them a great send off to the rest of their day. Thank you all. And Ava, thank you so much for your last minute sharing. So thank you for that. Appreciate all of you. Have a wonderful day, everyone.
Bye.
Bye.